Good morning. I'm Dr. Gorlitsky. Today I wanted to kind of do an audio presentation and go along with the PowerPoint slide that I did for the residents over here in South Carolina and for the medical students on hyponatremia. So full disclosure, I'm actually the CEO and co-founder of KidneyAide LLC, or UreaAide.com. We actually are distributors of two different ureas. We have our unflavored, self-flavored, bulk UreaAide urea, which has one ingredient, 100% USP grade urea. This can be used very effectively mixed with powdered Gatorade, powdered Kool-Aid, or any kind of like juice. We've had patients use pineapple juice, for example, or orange juice with a little stevia. And we are actually 60% lower cost than the U.S. competitor. We also have a premium packet that's individual dose packet. Those are 15 grams. And that's about 30% lower cost than our competitor. Both can be purchased directly through our website at ureaaide.com. We do sell internationally, and we are also on Amazon. It can be found on amazon.com as well. So just look up ureaaide.com or UreaAide on Amazon, and you'll be able to find us pretty easily. And we've shipped all over the world, including Mexico, Canada, Australia, lots of countries in Europe. So, and I'm going to kind of skip through a lot of the details of the presentation, just kind of go through some of the basics, and I think the audience that I'm speaking to here are pretty sophisticated and kind of understand the scope of the problem and don't necessarily need a case to review SIADH, understand the causes, probably know most of the treatment options as well. What we did at the end of the presentation for the residents was a taste test comparing ours to the competitor, and most people liked ours, especially mixed with the Gatorade powder, which is the way I prefer it. The scope of the problem, hyponatremia, is obviously very common. We know that. It can be as common as 40% in hospitalized patients. It is associated with increased morbidity and mortality, which we'll talk about. And SIADH is the most common cause of chronic hyponatremia. We had gone through a case of a patient who came into my office, hypertensive, euvolemic, but was sent for low sodium. You could see there the uric acid was low, which is kind of a clinical pearl that this may be SIADH. The thyroid and cortisol tests were within normal limits. We had done urine studies which showed a very high urine sodium, which is also consistent with SIADH. Urine sodium plus potassium was greater than the serum sodium, which tends to lend itself to the thought that fluid restriction alone wouldn't work. Also, the urine osmolality being above 500 is consistent with fluid restriction, probably not working. And so, of course, we did a kind of a cancer screening and made sure the patient was up to date, which they were. There was no obvious signs of cancer reported. The patient was fluid restricted, I think, before they saw me. And you could see there their serum sodium didn't really move much. It went up from 125 to 127. And actually the urine was, if anything, more concentrated. So the patient was still at risk. We had gone through, what do you do? Do you kind of ignore it? It's good enough? Do you get more aggressive? Do you add Lasix? Something else, perhaps? We had talked about some of the diagnostic criteria for SIADH, using the Schwartz criteria here. I think most of you guys are aware of these things, having a higher urine osmo, higher urine sodium, having normal thyroid and adrenal functions, typically normal renal indices, make sure the patient's not on diuretics, and some of these other pearls that we talked about, like having low serum uric acid. They also tend to have low BUNs. Some of the differential diagnoses we had gone through, cerebral salt wasting, which I'm going to skip over. We also looked at other lookalikes like hypothyroidism. Usually it has to be very severe hypothyroid, adrenal insufficiency. We talked about some of the consequences of untreated hyponatremia. Even if it's mild, we know that there's increased risk for mortality, falls, osteoporosis, and just general attention deficits, which they've actually studied and shown that it's similar to alcohol intoxication, kind of what we call the low sodium brain fog, which our clients also confess is accurate. And this was looking at a prospective population-based study that actually showed an increase in mortality for those patients who have hyponatremia, even mild cases. Another study showing increase in falls versus matched cohorts, as well as fractures, despite having similar bone mineral density. In that study, the authors concluded that hyponatremia would be a risk factor for fractures in the elderly. And there's an arrow there pointing to the age. These patients were about 70 years old, and even mild hyponatremia should be treated. Another study, case control study of a nice selection of patients, 122, also around 70 years old, and a mean sodium of 126 were looked at, and they did find overall increase in falls, 21% versus 5% in the hyponatremia group, which actually is a fourfold increase. And you can see even at the kind of modest sodium levels of 127 to 132, there was a high rate of falls. Some of these patients were also looked at in a little bit more detail, where they compared kind of treated hyponatremia versus untreated, and they used each patient as its own control subject. We had gone through the evaluation of the gait. How they did it is kind of complicated, but needless to say, the gait was worse, more trouble walking, more staggered kind of gait in the hyponatremia patients versus themselves treated. The gait instability also was compared, hyponatremia versus folks who consumed a modest amount of alcohol, and actually the hyponatremia patients performed worse in gait testing versus the alcohol patients. And this sort of talks about that the low sodium brain fog is real based off of this sort of trial and looking at compared to alcohol. And so patients with chronic hyponatremia do have more falls, do have more fractures, and perhaps we need to be taking it a little bit more seriously when you have a patient with chronic hyponatremia in your office, that we need to be a little more aggressive with our treatment strategy. Osteoporosis, so increase, this was rats looking at 3 months of induced hyponatremia, and they actually did have decreased bone density in the hyponatremia rats versus normonatremia. Also, the NHANES data looked at this and found that mild hyponatremia in humans showed a approximate threefold increased risk of osteoporosis. And then we talked about the treatment and if it overall does help. This was a meta-analysis showing there was benefit in mortality if you treated the hyponatremia at a meta-analysis level. And we talk about how it's tricky. It's not always so easy to treat hyponatremia. Your options are fluid restriction with a high protein diet, which probably wouldn't have worked in the case study that we talked about. Fluid restriction with salt tabs, same problem. There's Lasix and salt tabs. There's tolvaptan, and of course there's our friend Urea. So fluid restriction alone has been shown to be not very well effective. Up to 60% or so of patients will not respond to fluid restriction alone. And it's important to check that urine electrolytes and look at the urine osmolarity. And as we talked about, the serum sodium plus serum potassium, if that's greater, the urine sodium plus urine potassium, if that's greater than the serum sodium, then it's unlikely that a patient's going to respond to fluid restriction, and or if the urine osm is greater than 500. Here was a study looking at fluid restriction therapy for chronic SIADH, and what they basically showed is that 40% of the patients on fluid restriction alone did not reach a normal sodium or above 130 in this 46 patients with SIADH. So the authors in that study concluded that fluid restriction, although it did help to some degree, and it had a modest early rise, there was minimal additional rise afterwards, and over a third of the patients failed to reach even above 130, and that's after multiple days of fluid restriction. And they were just saying that there's more therapies that are needed for those patients. This is that first ratio that we talked about, that basically if the urine sodium plus urine potassium is greater than the serum sodium and or the urine osmos above 500, these patients tend not to do well with fluid restriction. They also talk about if you're in that 0.5 to 1 ratio, that a 500 ml fluid restriction may work, but I call that cruel and unusual punishment to put somebody on that minimal of a fluid restriction. That's a tough one for patients. So usually if you're seeing low urine electrolytes, lowish urine osm, you should get away with it. But if you're seeing close to a 1 ratio or certainly above a 1, you need to consider other options. A fused fluid trial came out fairly recently in 2020. This was a good study where they looked at fluid restriction versus Lasix versus fluid restriction, Lasix, and sodium chloride tabs. Basically, they showed at day 4, the sodium did increase by about 5 in all participants combined, with not a lot of difference between the 3 arms. There was a trend towards increased AKI in the patients on Lasix, and there was also a decreased potassium level with some of the more intensive interventions with the Lasix. And so the conclusion is, compared to fluid restriction alone, Lasix with or without salt didn't really further improve treatment of hyponatremia and SIADH, and did lead to a trend towards more AKI and certainly more hypokalemia. So it's not necessarily recommended to use this method for treating SIADH, especially in the chronic setting. And that's talking about that. More AKI and hypokalemia in the Lasix group. So we talk about urea. Urea has been used actually since the 1980s, mostly in Europe, originally in Belgium, Dr. Decaux. It's an osmotic diuretic. It also decreases sodium excretion, so it decreases natriuresis. Typical doses are about 30 grams a day. And urea was considered a good alternative in the treatment of patients with SIADH who present with chronic hyponatremia despite fluid restriction. And this is talking about a study from the 1980s, in fact, 1980. Urea was actually looked at versus tolvaptan. This was in a C. Jason study in May of 2012. I really like this study because of this chart. The picture shows 1,000 words here. You look at 1 year, first of all, on Vaptan therapy in chronic hyponatremia patients, and you see, folks with SIADH, you see that the Vaptan worked well. It kept the sodium level above 135. You see that those patients came off the tolvaptan for 8 days, and their sodium level dropped right back down. Then you put the patients on urea therapy, and you see a similar trend into the normal sodium range, also for 1 year. So this basically helped guide the European best practice guidelines to say, we ought to be using urea more than tolvaptan because urea works well. It's shown to be effective here, in this case, for 1 year or more. And it's a heck of a lot cheaper than tolvaptan, which, in America, tolvaptan is at least $300 a pill versus our unflavored urea, which is about $1.50 per dose or less. And so, in our opinion, of course, we'd like to see more folks using the unflavored UreaAide urea, as this will be equally effective, very safe, with minimal adverse effects compared to things like tolvaptan or Lasix plus salt tabs, which can cause, tolvaptan, of course, can cause liver toxicity. It really is only meant to be for 30 days prescription, only post-hospitalization, at least in America. And, of course, the fear of overcorrection and things of that nature. We talked about Lasix and salt tabs causing more AKI, potentially more hypokalemia, and not really being of that much benefit versus fluid restriction alone. This just shows the European best practice guidelines, which does show urea as basically a second line behind fluid restriction. at doses that are typical, which would be 0.25 to 0.5 grams per kg per day. They also shy away from tolvaptan specifically in these guidelines. So urea works really well because it is 60 grams per molar mass, and therefore a 30-gram dose of urea is 500 millimoles of solute. If your SIADH has a fixed urine osm of about 500, then that 500 millimoles of solute will lead to 1 liter of water diuresis. If we remember these kind of very simplified Edelman equation, we know that if you're able to hold on to salt and decrease your total body water, then that ratio of the serum sodium level will increase, and we'll see the blood sodium level rise. Salt tablets aren't great because you really give them 1 gram at a time, and so 1 gram of sodium chloride is about 34 millimoles of solute, and so you just need a lot of salt pills to even come close to what urea can do with 1 dose. And so just conclusions from this talk that we gave, that hyponatremia is common. It's proven to be both increases in morbidity and mortality. It's linked to falls, fractures, attention deficits similar to alcohol and osteoporosis. That the treatments that are out there aren't as effective as we'd like to believe. Things like Lasix and salt tabs, fluid restriction, or tolvaptan. And so urea, especially our UreaAide urea, is a great, inexpensive way to treat chronic hyponatremia. And we can be found again on Amazon. No prescription is needed. It is a medical food. We do sell internationally, and the best place and the lowest cost is ureaaide.com. And I thank you so much. You can follow us on Twitter, Facebook, Instagram. We're at KidneyAide. We are also on YouTube. Thanks, everybody, for the opportunity. Take care. Bye-bye.